area. So remember, it's a piriformis muscle in the buttocks. This is pectineus. And on our diagram here, it's the most lateral of our muscles. So if you're learning in sequence, when we look at the anterior thigh, you're going to see iliopsoas. Let me just go back briefly to iliopsoas. Well, we can use this model here. It's a little blurry, but this is the big model that we have in lab. So here is iliacus, and psoas major coming in as iliopsoas. And then these are the femoral artery nerve, and the pectineus right here forms a bed, if you will, for those muscles. Okay. So it's just medial to iliopsoas. Inserts on the femur, so not the trochanter, none of the trochanters or crests or lines, just below that, and does a deduction. Because it's slightly posterior in its attachment, it's going to be able to slightly medially rotate the femur. But that's in parentheses, so that's not one that I typically test on when they're in parentheses like that. Now we go even more medial, and we see the adductor longus. You can see that its insertion, or rather, is off of the pubic rami. Its insertion is posterior on the linea aspera, but again, with its angle, it's going to do a deduction. A deduction for all of these muscles, except we're going to add extension to our next muscle. All right. So all of these in the group are going to do a deduction, innervated by the obturator nerve. And now our next muscle is also going to be able to do extension. And that's because it inserts posteriorly all the way down the length of the linea aspera. So because it's coming from the posterior, when you look at the models, you take off the biceps femoris and you take off the semimembranosus and semitendinosus, the muscle deep to semimembranosus and semitendinosus is adductor magnus. It's huge. You're only going to see a little bit of it when all the model structures are in place. So if you go back to this image here, you're seeing a little bit of adductor magnus. Pointer here, if we take off the sartorius, but it's a huge muscle behind this one. Right? Hence its name. It fills in that triangular space created by the angle of the femur. So don't forget, make a note to take off the semimembranosus and semitendinosus and look at this muscle from the posterior aspect. It's a triangular shaped muscle, okay, or a pyramidal shaped muscle, and very fat from the posterior view. Because of its length, it's going to extend the femur. It does not cross the knee joint. It looks like it does. It goes to the adductor tubercle here, but it does not cross the knee joint. So it's only going to do those two functions at the head. Our next muscle is the only muscle of the medial thigh that crosses the knee joint, gracilis or gracilis. Very long and slender. Now this diagram makes it look like it goes at quite a bit of an angle, but because the knee comes inward, gracilis is almost running straight up and down. It's about 1.5 inches wide. It's a band-like muscle similar to sartorius. The two look very similar, but sartorius does go at an angle. Gracilis or gracilis almost goes straight up and down, but they both will insert on a very similar location right here, just below the condyles of the tibia. In fact, if you take Bio 122, our upper division cadaver course, this attachment between gracilis, sartorius, semimembranosus, and semitendinosus is called pes anserinus. It means goose's foot. And it looks like this red webbed foot structure of the goose. So those are all inserting there because it crosses the knee joint like the sartorius. It's going to flex the knee. Okay. So any muscle that crosses the knee joint, posterior or medial, will flex the knee. And that sometimes causes a sore point, over-exercise there just on the medial aspect of the tibia. So those are the muscles of the adductor compartment of the thigh. Okay, so before we leave and move into the leg, remember the thigh has 3 compartments: posterior, anterior, and medial. 3 different nerves for each of those compartments. Posterior compartment is what nerve? Tibial. Anything posterior is tibial, okay? And anterior is femoral or femoral, and medial is obturator. All right. Function of posterior compartment, we just went over, extension of the hip joint, flexion of the knee joint. One muscle does not cross the hip joint, and that's biceps femoris short hip. Okay? Looking at the anterior compartment. Single major function of the anterior compartment of the thigh. Well, we could have two actually. We have iliopsoas and psoas major come into the anterior compartment. Flexion of the thigh, but if we don't include iliopsoas, psoas major, well, let's look at that. What muscles do flex the thigh? Iliacus and psoas major. Rectus femoris, and one other muscle flexes the thigh. The only other muscle that crosses sartorius. Okay. The other major function of the anterior compartment of the thigh muscles, extension of the knee. One exception. What muscle flexes the knee in the anterior compartment of the thigh? It joins the gracilis by attaching medially to the tibia. Remember I said if it passes medial to the knee joint, it's going to flex the knee. Sartorius. Okay, so the others extend the knee, but sartorius passes around medially, so it flexes the knee. All right. Of the quadriceps femoris muscles, which one is the only one to cross the hip joint? We've kind of referred to it in its function. Rectus femoris. Okay, so if you're getting a little lost with all of the, learning it muscle by muscle, back off a bit, look for commonalities. So all the muscles do one thing except. All the muscles cross one thing except, or look for comparisons. All right, rather than trying to just memorize just each muscle by itself. Back away and do it as group structures. And that will give you almost as much information without the detailed mixing up of the muscles one within another. Okay, medial thigh, nerve is obturator nerve. All the muscles cross the hip joint. All the muscles function in adduction. One muscle crosses the knee joint, and that's gracilis. Okay, functioning in flexion. All right, now we're going to move to the leg, and in the leg we have three compartments as well. We lose the medial compartment that we had in the thigh, and we add a lateral compartment. So if you feel the medial aspect of your leg, remember leg is knee to ankle, you feel the medial aspect of your leg, you feel both. You're feeling the medial aspect of the tibia. There is no muscle attached to the medial side of the tibia. So there's no medial compartment. So in the leg, we have a posterior compartment, an anterior compartment, and a lateral compartment. With those compartments, you want to keep in mind where the tendons are passing. Remember in the forearm, if the tendons pass the wrist anterior, you're going to have flexion. If the tendons pass the wrist, carpal bones posterior, you're going to have extension. So when we look at the leg, we're going to pay attention to where the tendons cross the ankle joint. All the muscles that we talk about in the leg are going to cross the ankle joint. If they pass posterior to the lateral and medial malleoli, what does that function have to be? It's going to take the foot, point the toes downward. What do we call that? Plantar flexion. Okay? So posterior and lateral compartment muscle tendons will pass posterior to the lateral and medial malleoli. And they will both muscles of both compartments will do plantar flexion. Anterior compartment is the only group of muscles that pass anterior to the medial and lateral malleoli. And so it will be the only one that does dorsiflexion. Okay, so again, we've got those functions laid out by just looking at the compartments rather than individual muscles. Now, another function at the ankle is inversion of the foot, turning the medial aspect of the foot up, and eversion. So a muscle that is going to pull on the inside bones, the first and second metatarsals, is going to do inversion. Muscles that pull on this side are going to do eversion, no matter whether they are in the anterior or posterior or lateral compartment. Makes sense. So again, understanding the attachment is going to give you the mental and physical image of its function. Looking at the posterior compartment of the leg, again, our innervation is by the tibial nerve. We have 2 layers of muscles. Okay? Not as complicated as the 3 layers we saw in the anterior compartment of the forearm. Just 2 layers. The first layer is shared with 2 muscles. Gastrocnemius, which you're familiar with, is the calf muscle. It is the only muscle that we talk about in the posterior compartment of any compartment that crosses the knee joint. So the only muscle that we're going to talk about in the leg that crosses the knee joint is gastrocnemius. None of the muscles in the anterior and lateral compartment, whether we talk about them or don't talk about them, cross the knee. There are a few small ones in the posterior compartment that cross the knee joint, but we're not talking about them. So you can see the gastrocnemius has 2 heads that attach to the epicondyles of the femur. And that function, because it's posterior to the knee, is going to do flexion or extension. Flexion. Right? Those 2 heads, when we look at the tendons of the hamstrings, create a diamond-shaped space, which is the popliteal fossa. Insertion is via the calcaneus tendon, which you've probably heard of as the Achilles tendon. And insertion is onto the calcaneus bone. So that is a common insertion for the gastrocnemius and for the soleus. Soleus is just deep. You'll notice it doesn't come off of the femur. It does not cross that joint. So it shares an origin from both the tibia and fibula. It looks very similar to gastrocnemius, which is not as long. It's actually a bigger muscle. It has more of a muscle belly. The gastrocnemius muscle belly is quite high, and that's what gives the defined shape to the back of someone's calves if they're a biker or a runner. But soleus is going to extend farther distally, okay? And it actually is a greater mass. Because they pass posterior to the lateral and medial malleoli, both of them are going to flex through plantar flexion. Both of them are going to point the toes downward. That's the only thing the soleus can do, because it doesn't cross the knee joint. Okay? Now, if you feel the back of your ankle, what we call the ankle, you'll feel that calcaneus tendon. It's very thick. Okay? It doesn't stretch very well. When I took I was at the doctor's office with my son once, and the physician was telling me about another patient he had, a guy who had grown so fast that he actually ruptured his calcaneal tendon because it wasn't keeping up in growth with the bones, the increase in length of the tibia and fibula. But stretching does help. A friend of mine tore her Achilles tendon playing softball, running from home to first base. Again, she hadn't even done any kind of the stretches at all. So it's a big, massive amount of connective tissue. But remember how long the calcaneus extended posterior from the joint of the tibia and the talus? That's a gap that just has connective tissue. It's not filled in with muscle. And so we have that bit of space before we see the tendons for our next layer. And there are 3 muscles in our next layer. All 3 muscles will send their tendons medial, but posterior. So they're going to go behind the medial malleolus of the tibia, pass posterior to that, and enter the foot. Because these 3 muscles all function to move the foot and or toes. So we're going to see plantar flexion for all of them because they pass posterior to the malleoli, right? And then depending on whether they go to the digits or just go to the metatarsals, they will move just the foot or they will move the toes. This is a flexion compartment. And if you miss that or you forget about that, you have toes. All you have to do is flex and extend your toes and feel which muscles are working to do that. So if this is representing my leg and this is my foot, flexion of my toes is this movement or that or this movement. Curling them under. So to curl them under, I have to use the muscles in my posterior compartment. So that's my flexor compartment. Remember the leg in comparison to the forearm is rotated. All right, so My flexor muscles are going to be in the posterior compartment coming into the inferior aspect. So here we're going to do, notice the tibialis posterior attaches to our first metatarsal. So we're going to plantar flex the foot because it goes posterior to the malleoli. Because it goes, even though it's posterior, because it goes to the first metatarsal, it's going to do inversion. Right? So if it goes around this side, it's going to do inversion. If it does this side, eversion. So posterior tibialis goes behind the medial malleolus, so it does plantar flexion, inserts on the first metatarsal, so it's inversion. The next muscle has its function in its name, flexor digitorum longus. So it is going to go to digits 2, 3, 4, and 5, and it's going to flex the toes. It's also going to do plantar flexion because it goes posterior to the medial malleolus. All three tendons, as I said here, go posterior to the medial malleolus. I'm going to come back to that picture in just a moment. There's a really cool piece of engineering. We don't learn muscles on the bottom of the foot, on the plantar surface. But notice the angle at which this tendon comes into those toes. So if we left that muscle just like that, and you flexed your toes, they would all flex like this. Okay? They would all flex towards the big toe because of the angle of those tendons coming in. And there's a cool little muscle that fits right here that straightens that out. So when you flex your toes, they flex straight under themselves instead of at an angle. We don't need that in the wrist because our tendons come straight into the wrist. Do you guys recognize MP and IP, what those mean? Metacarpal phalangeal, okay, which in your hand would be the knuckle joint, and interphalangeal. So these tendons go all the way to the distal digits, right, to the distal phalanges. As such, this muscle is representative of flexor digitorum profundus. Remember that was the one that flexes distal fingers, joints? Okay, finally we have flexor hallucis longus. Hallucis is our Latin word for big toe. Well, what's our word for thumb? Remember the muscles that are in italics? Pollicis. All right, so pollicis is thumb. Hallucis is big toe. And when I was in high school, the way I remember this, in college, the way I remember the difference was halitosis is bad breath, and your big toe is more likely to stink than your thumb. So hallucis is big toe. So flexor hallucis longus goes and flexes the big toe. Notice, however, that it comes off the fibula. The muscle in our forearm that you didn't have to know that flexes the thumb makes sense. It's on the thumb side of the forearm. But in our leg, it crosses all the way over. So when we get to lab, it makes it somewhat difficult to be able to figure that out. Yeah, it's not just keeping it straight. So this is looking at the medial aspect of the three tendons. And as you look at them anterior through posterior, the most anterior tendon is for the posterior tibialis, where it says posterior tibia. The next tendon is for flexor hallucis longus, and then the most posterior tendon is for flexor hallucis longus. So there's a little saying, Tom, Dick, and Harry. Tom for posterior tibialis, Dick for flexor digitorum longus, and Harry for hallucis. And that's the order in which you see those tendons right there at the ankle. So in lab, I'll point that out. And at the beginning, until you recognize the pattern on the posterior leg, it can be helpful in figuring out which of those muscles is which, because they don't line up where you think they should. All right, so those are the 5 muscles of the posterior compartment of the leg. All 5 do plantar flexion. Tibialis posterior also does inversion. Flexor digitorum longus flexes digits 2, 3, 4, and 5. And flexor hallucis longus flexes the big toe. So their function, except for tibialis posterior, is in their name. Now as we move to the lateral compartment, there are only two muscles in this compartment. They have the same function. Okay, they insert onto different bones, but they have the same function. The nerve of the lateral compartment is the superficial fibular nerve. It passes around the fibula and into the lateral compartment to innervate these two muscles. Origin is off the fibula, hence fibularis longus. Old name is peroneus. So if you see that, it's the same thing. It's just easier to remember fibularis in the lateral compartment. Notice these two tendons are going to pass lateral, or rather posterior to the lateral malleolus. It makes sense. They're in the lateral compartment. But again, because they're passing posterior, function is going to do plantar flexion. Along with plantar flexion, are they going to do inversion or eversion? Notice they're going around the outside of the foot. Both of the tendons are going to pass around the lateral aspect of the foot. So here's fibularis brevis, fibularis longus, lateral aspect of the foot. Both of them are going to do eversion, right? Fibularis longus passes under the foot, as you can see in that diagram, all the way to the first metatarsal. So it shares that insertion with the posterior tibialis. However, posterior tibialis gets to it from the medial side. Fibularis longus gets to it from the lateral side, so they have opposite functions, even though they have the same insertion. So posterior tibialis does inversion. Fibularis longus goes all the way around to here, so it's doing eversion. Same bone, but getting to it from opposite angles. So both fibularis muscles will do plantar flexion and eversion. The insertion of fibularis brevis is short, fifth metatarsal. Now in the models, you won't be able to see the insertion of longus because it's covered up by the muscles of the foot, but you can see the insertion of fibularis brevis. And the muscles tend to blend into each other in the compartment, so I usually tag the tendon. So any of the muscles that are tagged, the tendon, naming the muscle is fine. It's just sometimes like semitendinosus, the tendon is a little bit easier to pick out. Now, I killed the nerve to this compartment when I was in labor giving birth to my first son. It wasn't really long, it was 2 hours. But as I had an epidural, so I wasn't in any pain or anything, but I would grab my knee and hold it like that to push, and the palm of my hand was compressing the superficial fibular nerve against the bone of my fibula. The same damage can be done wearing ski boots that are too tight. I didn't notice anything. Chris was born on a Monday morning. We got home. I go to church on Saturday, so I went into my closet to put on my dress shoes, which, I mean, I'm 5'10", so I don't wear really high heels. And they were about 1.5 inches, 2 inches. I couldn't walk out of my closet. Walking around, he was born in August, so walking around in flip-flops was easy. Tennis shoes was fine. But get up on a couple of inches of heels, and my foot rolled out. So the function of these two muscles is stabilization, all right? So eversion of the foot is to pull the ankle this direction, to pronate, if you will, the foot. And when those aren't working, my foot just kind of rolled over like that, and I couldn't keep my balance. I had to wear flat shoes. Peripheral nerve, if the surrounding connective nerve cells, tissues are fine, will grow back at the rate of about 1 to 2 millimeters a day. So, took several months, but I got the nerve function back. Okay? But I really could tell for the first month or so the absence of these everter muscles. Lateral compartment, only 2 muscles. They have the same function. Anterior compartment. So we have 3 muscles that we're learning in the anterior compartment, starting medial and moving lateral. That's getting annoying. We have tibialis anterior. Notice that it doesn't cross the knee joint either. It inserts on the first metatarsal, just like tibialis posterior, or you could say posterior tibialis, fine. And so it's coming down like this, and you can actually see this tendon on your foot if you were barefoot. You can see the tendon going right to the first metatarsal. Is that going to do inversion or eversion? inversion. All right, so you can see that tendon pulling up on the first metatarsal inversion. So we have a case here where anterior tibialis and posterior tibialis are both antagonistic and synergistic. They're antagonistic because tibialis anterior is going to do dorsiflexion. Tibialis posterior is going to do plantar flexion. Again, because the tendons are going anterior or posterior to the malleoli. However, they both insert from the medial aspect to the first metatarsal. So they're going to be synergistic for the function of inversion. We have a similar thing with our flexor carpi ulnaris and extensor carpi ulnaris. Antagonistic because one flexes, one extends, but they're both going to do ulnar deviation. Flexor carpi radialis and extensor carpi radialis longus. Again, antagonistic because one flexes, one extends, but they're both going to do radial deviation. So, dorsiflexion, but inversion. Extensor digitorum longus. Extensor hallucis longus is deep. Was that my next one? Extensor digitorum longus is just lateral to tibialis anterior. Notice again, its tendons are going all the way out to the toes, hence the name digitorum. Doesn't cross the knee joint, crosses the ankle joint anterior, so it's going to do dorsiflexion and extend the toes. Again, function is in its name. And then we have extensor hallucis longus. This tendon, you can see, like the one on my thumb, you can actually, if you extend your big toe, you can see the tendon going all the way out to the tip of the big toe. It's going to do dorsiflexion and extend the first digit. The nerve to this compartment is the fibular nerve. The common fibular nerve is often damaged when giving an injection. So if we go back to looking at the buttocks, just have to bring it down here where I can reach it. So when giving, I used to be an RN, and when giving an injection in the buttocks, all right, this is the medial aspect where it's coming off of the sacrum. You want to avoid the sciatic nerve, all right? This happens to be, I'm right-handed, so I would be going on the other side, but let's say I was left-handed. Obviously, this is way bigger than any buttock I ever injected, or my hand is shrunk. But I would go in like this, okay, and then give the injection in that angle of my hand, so you're in the upper outer quadrant of the buttock region. That avoids the sciatic nerve. Now, if you were to slip and get the sciatic nerve, are you more likely to get the tibial or the common fibular aspect of that? Which one is the lateral portion of the sciatic nerve? Tibial is medial, going all the way down the leg. Common fibular is lateral because it's going to give a lateral branch going out the superficial fibular and deep fibular going off of that. So if it is hit by, especially someone getting a penicillin shot, which is several mils or cc's of antibiotic, it's usually the common fibular that is damaged. And so someone who has damage to this nerve often is described as having foot drop. So when you walk, what do? You push off with your foot. Is that plantar flexion or dorsiflexion? Plantar flexion. Tibial nerve or our fibular nerves? I'm going to do plantar flexion. Am I doing posterior compartment or anterior compartment? Posterior compartment. So tibial nerve. All right. So that I can do fine. Tibial nerve usually isn't damaged with injections. If I push off, and now I bring my foot forward to plant my heel, I have to do dorsiflexion, all right? And that requires the deep fibular nerve. So only my anterior compartment can do dorsiflexion. So if that has been damaged as part of the damage done by the chemicals in the injection, foot drop exists, and so push off, and then I can't lift my foot up, and so I drag it forward, and then slap, okay? And so that's often a telltale sign of damage to the nerve. So you walk, you drag the foot forward on top of the foot, the top of the foot drags, and then the foot lifts up and then slaps down because they can't bring it down slowly, right? So that foot drop and then slap is a common indication of damage to that nerve. Alrighty, so we're done with all the muscles. We've got a little bit, half an hour or so to do some review. Let me just see if I can pull something up here. That is considered to be, it's not one you have to know for lab. It's considered by some to be a separate muscle of the, but others consider it to be part of extensor digitorum. And so extensor digitorum longus comes out to the digits. Tertius is a small branch that comes down and helps in eversion. But it's not one that you get tested on in lab.
Are you not going to cover muscle tissues in class that be responsible for?
No,
We're not.
that won't be on it at all.
Oh, okay.
Okay.
They're all on ChatGPT too, right?
Not these.
Not these.
I'm looking, but for some reason I am not being able to open up my lab exams in AR are on PowerPoint. And okay. So your lab exams are not multiple choice, and mine at AR are not as well, but this is just a review. So remember I had to add 3 terms, even in Lancaster's class, I had left it up on the board. I wanted you to add 3 terms dealing with the anterior abdominal muscles. So the arrow is pointing out which of the structures up on the screen. But it's a central one. And then the semilunaris, we have 2 of. Those are, I point out things in the lab room. I'll have to use this one here. So that would be here. And what are these right here?
Tendinous insertion.
Tendinous insertions. Okay. Where do we find the fascia latae?
The back.
Lateral aspect, the icy band. Okay, so tensor fascia latae is going to move into that. And the gala ponderotica has nothing to do with erotic. So that's the band of connective tissue between what 2 muscles? Frontalis and occipitalis. Okay. We'll do some of the ID and nerve, and then I'll do another type of discussion. So what are we looking at here? Latissimus dorsi, a very large muscle of the back. Most of the muscles in our back are going to be attached to the scapula, the trapezius or the rhomboideus. Latissimus dorsi is attached to the humerus, okay? And what is its major function? Extension, okay? So extension is this movement, remember? So there was a discussion in one of the labs about, well, I thought extending your arms over your head, you do that. Well, that may be described in layperson's terms. But for us, going up like that would be flexion of the humerus, and extension is what latissimus dorsi does. So just insertion is just the shaft. It also will do rotation. You're going to do medial rotation or lateral rotation. Comes up from the back, swings underneath, and grabs onto the humerus right here. So when I grab the humerus there, medial rotation. Okay? So for those of you that are still confused on rotation, pretend I'm the humerus. Okay? I've done a lot of different anatomical things. So today, I'm the humerus. My body's over here. All right? So medial rotation would be turning in towards the body. So I have my elbow flexed so it doesn't look like I'm doing pronation and supination. And then lateral rotation is turning away from the body. All right, so that's same thing with the femur. I'm going to flex my knee. That's not part of the rotation. It's just like I flex my elbow. Look what happens to my foot when I immediately rotate my femur. Turning in towards the body. So notice my foot goes lateral as I rotate my knee. That didn't happen when I rotated my humerus. My hand also came medial. But remember, the knee joint and the elbow joint are flipped. So if I rotate my femur medially, it's that way. When I rotate it laterally, turning it away from the body, my knee crosses over my body. Okay? But it's the bone, the femur of the bone that's being moved. Well, that's what we're looking at here. Good. Interoblique. So you pair those fibers on both sides, and you have the upside down V. All right. For some students, it's confusing because they see the fibers of the external oblique on that side. They're going in the same direction, so this side must be external oblique as well. But it's not. You have to imagine the opposite side there, and that's the upside down V. Okay. Anybody remember the nerves that innervate the anterior compartment? They both start, they come together, it's L1 and L2. They both start with ilioinguinal, iliohypogastric. Okay? They're kind of the equivalent of our intercostal nerves. So, what's this bone right here? Hyoid, and the part of the hyoid is the bend of the hyoid. So you know that genu is going to be part of that name. And this whole massive structure is the tongue. So it's genioglossus. All right, what's the function? Pushes the tongue forward, sticking it out. All right, and the nerve has glossus in it, cranial nerve 12. Passes out that opening just superior to the occipital condyle. Hypoglossal. So hypoglossal nerve. Now we have geniohyoid on here and mylohyoid. Those are the three muscles that we can see from this view. So in order, this lowest one, mylohyoid, and that one, geniohyoid. Okay? Those have the same insertion. Both of them actually have the same origin from the mandible, but the mylohyoid has a broader surface. Geniohyoid is just the genu. And so they share the same origin, share the same insertion, have the same function. They are suprahyoid muscles above the hyoid, so what are they going to do? Elevate. They're going to pull the hyoid and the associated voice box or larynx up with it. Okay, these we just learned today, so you may not know that one, but this is, over here is iliopsoas, here is pectineus, right next to that one is adductor longus. Okay, so the nerve is obturator nerve, and right next to it here is gracilis. Without taking off sartorius, you're not going to see adductor magnus. So the other ones that we can see on here, sartorius. What's this one right here? The coffee muscle? Tensor fasciae latae. You You can see a little bit of the IT band along the side. Here we can see 3 of our quad muscles. This one in the middle, rectus femoris. What's its origin? 2 inches below these 2 muscles, sartorius and tensor fasciae latae, are sharing the first part of the cliff that you jump off into the waters of Acapulco Bay. Anterior superior iliac spine. Okay, if you don't jump out far enough, you're going to land on the second level, the anterior inferior iliac spine, and that's the origin for rectus femoris. Okay. Vastus lateralis and vastus medialis come off of the femur, and they're not going to cross the hip joint. So anterior compartment or posterior compartment? Posterior compartment, what nerve? Radial nerve. Origin, what's the muscle first? Brachioradialis. So it's the one that forms that bulge right here. This is the only one of that compartment that doesn't come off of the lateral epicondyle. So it's coming off of the humerus, the shaft of the humerus, just above that. Does it cross the wrist joint? No. No. So insertion is, it's in the name, radius. All right, so origin is humerus, brachio. Insertion is radius, radialis. Doesn't cross the wrist joint. So it wraps around here. When it pulls, supinates. Okay? It's going to also weakly flex, but I kind of ignore that. Major function is supination. So we have 3 muscles that do supination. The prime mover for supination is biceps brachii, which inserts on radius, radial tuberosity. Okay? Then we have brachioradialis, also inserts on the radius. And the muscle deep to brachioradialis, supinator, obviously supinator. So while we're looking on this, these are all of our flexor compartments. What nerve innervates the flexor compartment of the forearm? Median nerve. And so the only one that doesn't cross the wrist joint, pronator teres. All the other ones will cross the wrist joint. What's their common origin? Medial epicondyle. Okay. Pronator teres inserts on the radius as well. So whether you pronate or supinate, you have to insert on the radius, because that's the only bone that moves as we pronate or supinate the wrist to turn the hand. Okay? So as we go in order then, next to, this is the large muscle model that we have in the lab. So what would this muscle be? Sensor carpi radialis. Crosses the wrist joint because it has the word carpi in it, and all of the muscles cross the wrist joint in the forearm, anterior forearm, except for pronator teres. So it's going to weakly flex the elbow. Major function is flexion of the wrist. And then because it's on the second metacarpal, it's going to do the radial deviation. Okay? You can barely see the tendon for palmaris longus. Does that do radial or ulnar deviation?
No.
No, because it just goes in straight into the palm. Okay? And then what is this muscle that we can see between the tendons of those two? Or intermediate layer, I'm hearing it, flexor, digitorum superficialis. All right? Does that insert onto the proximal, middle, or distal phalanges? Middle. The one that forms that fork. All right? We talked about these muscles on Monday, but we haven't spent most of your lab probably looking on the arm. So this is lateral compartment of the posterior thigh. You can see this group of muscles going medial have 2 groups. This is actually gracilis there. So the arrow is pointing at biceps femoris longus. Nerve, posterior thigh, posterior leg, tibial nerve. Function, we went over this earlier. Extension of the hip, flexion of the knee. And you can see down here, I don't know if I have another model where it's missing. This is that common fibular nerve going lateral. And so that also tells you this is the lateral compartment, or the lateral muscle of this compartment. So here's the lateral compartment of the leg. You can see the calcaneus tendon attaching to the calcaneus. And this is a lateral compartment innervated by superficial fibular nerve, and here are the two tendons. So fibularis brevis, inserting onto the fifth metatarsal. Fibularis longus disappearing. You can't see the rest of it. It's kind of like the long head of the biceps brachii. But you can see the attachment of brevis. So that's the deeper muscle. Okay, usually it's the superficial, but it's the deepest muscle here. So I will tag it somewhere around here where you can pick out and discern between those two muscles a little bit better. Two functions. I know we just went over it. Posterior to the malleoli, plantar flexion. Lateral to the foot, eversion. Okay, this is the tibial nerve. You don't have to identify the nerve for this class, but we are looking at the posterior compartment. See how these three tendons all pass behind the medial malleolus? So this is the tibia. So you would, rather the fibula, this is the fibula. So tibialis posterior is in the middle. Fibular flexor hallucis longus comes off, opposite of where you think it would come off. You think it would come off in line with the big toe, which is the tibia. But instead it comes off with the fibula and crosses over. So in the lab, this is going to be flexor hallucis longus. This will be tibialis posterior, and this is flexor digitorum longus.
Teres major.
Great. Teres on this one, yes, that would be teres major. You can't see the tendon itself because of the capsule was in the wrong place. What would this one be? Supraspinatus and infraspinatus. Similar area, but in the lower extremity. Gluteus medius. Gluteus maximus has been cut, and gluteus minimus is not on, it's on the model. I mean, it's not made on the model, but it's because it's covered up by gluteus medius. Major function of this muscle? Abduction. Okay. Gluteus maximus is going to be extension. Gluteus medius is abduction. We'll also do medial rotation. Major function is abduction. You can see the sciatic nerve. And this one, piriformis. Skip one. And here's obturator internus. Bless you. All right, we're looking at radial nerve here. You guys don't have to identify the nerve yet. This is the big model of the forearm. So we're looking at tendons of flexor carpi radialis, palmaris longus, and the flexor carpi ulnaris muscle. So this muscle is flexor digitorum superficialis. Temporalis. What's the nerve that innervates this muscle? Not a muscle of facial expression. It does not insert into the skin. Trigeminal. This is a chewing muscle. It goes to the coronoid process, so it's going to move the mandible. Okay. Anybody know what this muscle is right here? Levator scapula. See it inserting onto the superior angle of the scapula there. You identified that already. Unfortunately, we don't have this model in lab, but we do see the muscle on the chart. Platysma. Okay. No boning insertion. This is a muscle of facial expression, so facial nerve. Trapezius. Okay. What about this group of muscles here?
Erector spine.
Erector spinae. And this muscle here? Latissimus dorsi. So pec major forms the anterior wall of the armpit or the axilla, and latissimus dorsi forms the posterior wall. Okay. Obviously deltoid here. What would this muscle be right here? Yeah, brachioradialis right here. Dorsi. Sartorius. Sartorius, remember, starts lateral up high at the anterior superior iliac spine, passes medial, superficial to all of our quad muscles. So that is sartorius. Remember the innervate sartorius? Anterior compartment of the thigh. Femoral nerve. Function of sartorius, it crosses two joints just like rectus femoris does, so it has the same function at the hip joint. Flexion of the hip. Crosses medial to the knee, so instead of extending the knee, it's going to flex the knee. Because it goes from lateral to medial, it's going to do lateral rotation. You don't have to know that one. This one we already talked about. Mylohyoid. You don't have to identify this nerve for this unit, but I had talked about it earlier. This is ansa cervicalis. Remember I said it forms a loop along the neck. What's the one muscle, one infrahyoid muscle that we discussed? Sternohyoid. That's innervated by ansa cervicalis. Okay, it hangs below the hyoid bone. Vader scapulae. You don't have to know. Lineus capitis. Function. Yes. Extension. But what else? It shares that function with semispinalis. Extension of the cervical vertebra. But what else does it do? Turns the head from side to side. And it shares that function with sternocleidomastoid. So those are another pair of muscles that are antagonistic and synergistic. So the antagonistic function is when we use sternocleidomastoid together, flexes the vertebra, lineus capitis extends the vertebra. Both of them turn the head from side to side if we use one at a time. Okay? Innervation. Any of our deep muscles of the posterior back are innervated by unnamed nerves, but what do we call? No? Accessory goes to trapezius and sternocleidomastoid. Unnamed nerves. Dorsal rami, just the posterior branches of the spinal nerve. Obturator internus. Okay, up here would be, the superior muscle would be piriformis. Function of obturator internus and piriformis. Think about the infraspinatus and teres minor. Those would be the equivalent muscles at the shoulder joint. Lateral rotation. You can see it's coming out here. It's going to grab the greater trochanter and pull it around like that. Lateral rotation. Vastus lateralis would be here. Tensor fasciae latae. Okay. Now, if we look at this, here is biceps femoris long head. Here is short head. What would this muscle be right here? Still part of vastus lateralis. If we were medial, it would be adductor magnus. Those we talked about already. Tilt your head. So we're looking looking at posterior leg. My arrow moved. So looking at posterior leg. This would be tibialis posterior. We're on the little toe side. And when we're on the little toe side, that's the muscle that actually moves the big toe. So flexor hallucis longus, tibialis posterior, flexor digitorum longus. No, it should be easy. Sensor hallucis longus. Lateral pterygoid. Innervation. Doing muscle. Trigeminal. Is this muscle going to pull the jaw forward or pull the jaw back? Is it going to protract or retract? Protract. What's the only muscle that retracts? Temporalis. It's the only one that has fibers that have their origin posterior to the temporomandibular joint. Buccinator, okay, or buccinator. This muscle right here would be masseter, and this one right here, sudorius. Down here, depressor, labii inferioris, and up here, levator labii superioris, and then zygomaticus, so major being the only one we see there. Okay, the only muscle, well, we have three muscles in the anterior arc. One crosses the shoulder joint, one crosses the elbow joint, and one crosses both. Brachialis. Prime mover for flexion, therefore it inserts onto the coronoid process of the ulna. That's our joint for flexion. Big muscle. Brachialis. Looking at the nerves. Those, so that one. Diaphragm. What do we call this area, white area right here? Central tendon. Serratus anterior. Origin, the ribs or the scapula for normal function? Ribs for normal function. Scapula if we want to use it to assist in respiration. So normal function, as you can see it there, is to pull the ribs forward, okay? To adduct them, pull them forward against the ribs, pull the scapula forward. Oh, this is a tendon of flexor digitorum longus, and this is that muscle I told you about that straightens out its movement. You don't have to know it, but. And the one in the middle? Longissimus. Starry tongue model. So the white arrow coming off the hyoid bone, which is number 1 here, going into the tongue, hyoglossus. That stabilizes the tongue and depresses it. All right. So this muscle up here, styloglossus, pulling it up and back to think of its origin onto the styloid process. And then again, from the outside lateral view, we see genioglossus, geniohyoid, and mylohyoid. Those you don't have to know. These are from my class at AR, and they have 6 hours of lab a week. So, okay, this is what I was telling you about. So this is gracilis. This is posterior thigh with the hamstrings gone. This is medial. So you're seeing gracilis here. All of this, so semimembranosus and semitendinosus would be here. All of this is adductor magnus. Okay, you can see much more of it from this posterior view. What's this muscle here? Short head. Short head. So here's the sciatic nerve, and this is the common fibula going lateral, and tibial nerve continuing straight in the pattern we talked about earlier. White arrow. I told you this was the short head. Would you know what muscle it was? This is coracobrachialis here. This is short head of the biceps brachii. Okay? And the black arrow is on subscapularis. What would this muscle be here? Teres major. All right, we haven't looked at these in lab yet, but here's the anterior leg, closest to the tibia, inserting on the first metatarsal, anterior tibialis. Then the next muscle over is extensor hallucis longus. You won't be able to, extensor digitorum longus. You won't be able to see the muscle for extensor hallucis because it's deep to these two, but you can see it's tendon coming down here. So the last one. So the arrow 56 is on vastus lateralis. Okay, alrighty.